I want to welcome you all to our first boot camp this year. This has been the fourth year we've done this style of boot camp, and each year only gets bigger and bigger. First off, I want to thank the most important people who are behind this sort of these boot camps that we have: Katrina, Kelly, Allen, and then our most recent prior alumni directors, Elise as well as Jess. Without their incredibly hard work, this boot camp would not be possible. We're all honored today to have our wonderful alumni, Dr. Chen, as well as Dr. Khaira, leading our talk today, some of whom have been repeat lecturers. Lastly, to our attendees, thank you all for joining. I hope you guys are able to take away some key pearls as well as you guys head off to your sub-Is as well as your rotations. As you can see, this APAMSA family spreads wide across our country, and we love to have all of our alumni join us and help us as mentors, speakers, as well as advisors. So thank you all for coming. Now I'll go ahead and give the floor back to Kelly and Katrina.
All right, thank you guys for coming to our 2025 APAMSA Bootcamp Series, Psychiatry Edition. This is our first bootcamp of the year. And as a reminder, we have 6 other bootcamp sessions. Internal medicine is on Friday, surgery is on Sunday, and then we have a couple more throughout May. And then just some ground rules for audience participation. So while the presenter is speaking, the remaining speakers will be answering questions in the chat box. And then we also welcome audience participation. So raise your hand if you'd like to answer a question or ask a question. And if you're speaking, please announce your name, school, and year of training. And this is just an overview of some of the high-yield psychiatry topics we're going to be covering today. And without further ado, I'll turn it over to our first speaker.
Okay, I'm going to bring up the slides right now. It's nice to see everyone here. Thanks so much for being here on a Wednesday evening. So let me keep going. So, okay. Is my screen good? Okay, cool. All right, so my name is Mary. I am a PGY3 psychiatry resident over at Brigham and Women's Hospital. I'm from Chapel Hill originally. Things I'm interested in are mood disorders, psychedelics, leadership development, and then cultural psychiatry. And then outside of work, I love doing yoga. I eat Mexican food probably like every single day. And then I also like playing the ukulele. So first I'm going to talk about consults. And so first, just broadly, like what is the purpose of consults? And it's really these 4 things. You're going to answer a specific question. And honestly, you get to be a really good advocate for the patient. And by doing this, you can promote collaboration between the patient and the team. And honestly, in the literature, we see that like psychiatry consults do improve outcomes. So that's the reason why psychiatry is like one of the few specialties that has consult liaison. Psychiatry is one of the fellowships. And so now I'm going to talk about how to present. And we all know how to present, but things that I think are really important are how to give a tight, efficient, effective presentation that will make your attending think, okay, wow, they really know what they're talking about. And so because you guys all know like the basic structure, I'm basically just going to give you 5 tips. Okay, so first, you're going to give the spoiler first. So this is the only time that you'll want to tell like the punchline first. You're going to tell people what the plan is. And this frames the presentation. This allows your audience to focus on what you're saying rather than wondering where you're going with your presentation. And then next, order matters. So being able to go in order so that your senior or attending can organize the information in a linear way is super important. And then as you're presenting, just make sure that you're considering the differential. So you should have a differential of like your top 3 most likely diagnoses, adding in information that can support or detract as you go along. So for example, if you find out that this patient's great grandma had anxiety, then you probably can leave that out. If you find out that this patient had a suicide attempt last week, you can definitely leave that in. I like to keep my presentations presentations 2 minutes or less. This might be attending dependent, so you can kind of feel out the vibe and see if they want a more involved presentation or not. And then finally, you can answer questions. And so, so basically, you can always keep your presentation short so that you can fill in the gaps and so that you just have the information ready. So we're gonna just jump in and do a little exercise where you get this case. And so I'll put the tips from the last slide in the chat, but let's just run through this case, think about how you would present it, and then we'll go through what an efficient presentation for this might look like. So why don't you take like 3 to 4 minutes to do this? Okay, so just like we said, we're gonna start with the spoilers first. So imagine that you have this attending coming up to you. He looks like this and he says, "Are you ready to present?" And so in terms of, so first of all, let's take a step back. Oh, sorry, one sec. So basically spoilers first is yes, you can say, yes, I think we need to section this patient and start a bed search when we can confirm he's no longer under the influence. But let me start from the beginning. And so going next in terms of order matters. So let's start with by talking about the one-liner as well. And just to like put this out there, what are 3 good things that a one-liner should tell us apart from demographics, comorbidities, things like that? And the things that you want to know are the level of risk, possible differential diagnoses, and then the question that we're trying to answer. So for example, this is a 24-year-old male, past psychiatric history of schizophrenia, cannabis use disorder, otherwise healthy with 1 prior hospitalization, who was brought in by EMS, sectioned by police. We were consulted for a safety evaluation. And so from this, we can already tell that the possible diagnoses are decompensated schizophrenia, substance-induced psychosis, etc. We can tell that the level of risk is high because they've been hospitalized before, they were brought in by EMS, they were sectioned by police. And then the question that we're trying to answer is, of course, is this for safety evaluation? And the question, if we were like getting more granular about it, is this person safe to go back into the community? Okay, so next we're going to consider the differential. So this is important because everything in our presentation should either be answering the question we're supposed to be answering, basically, is this person safe to go back into the community? And either directly pertinent or to ruling in or ruling out the differential. So for example, in the history, there were a couple things that you probably didn't need to include. So like, and then if you think about it more generally, if you're rolling out something like bipolar disorder, you probably don't need to know that the patient enjoys playing basketball or was in the military, things like that. And then I think it's important to keep, like I said, the presentation to 2 minutes max, unless it's really complex or you have a really wide differential, so that you have a lot of evidence to present to rule things in or out. And then again, you have to kind of get a feel for the vibe of the attending and if they want something that's really like very comprehensive, or if they're okay with something a little bit faster. And going forward, then if we kind of go through what we've gone through so far, the attending asks, are you ready to present? Then you start with a spoiler. Yes, I think we need to section this patient and start a bed search, but let me start from the beginning. Then you can say your one-liner. And then just to give an example of what this might look like is this. And you'll definitely get these in your slides, but what I would say is, yes, this is a 24-year-old male, history of schizophrenia, brought to ED by EMS for bizarre behavior. And then you can talk about your HPI, which is how he was presenting. He was found out he was yelling about being followed by drones and trying to climb into other passengers' cars. You can talk about his MSE. So on ED eval, he was guarded, internally preoccupied, and refused to remove his hoodie or sunglasses. You can talk about his symptoms. So he endorsed poor sleep for several weeks. He has no appetite. He's not sure if he's taking his medications. No thoughts about hurting himself or others. He was sectioned by police. And so as we go on, and then this is how you would essentially go from there. As you can see, you can definitely say this in about 2 minutes, and it goes through all of the information that you need that's relevant, that's not relevant, and basically you can talk about your differential, you can talk about what you think is most likely going on, and then what you think, like in terms of his safety, what you would do next. It's also really important, of course, for any safety evaluation to talk about risk. And so given that this is a pretty high risk patient, you would think to section this patient, you can reevaluate when sober, and if symptoms persist, then you can start the med surge. And then you can also talk about med plans too. But I think the most important thing in terms of your plan is just being really direct, showing the attending that you've thought through all of the possible aspects of the differential, and also just the fact that you can be very thoughtful and efficient with their time as well. Any questions about that? Okay, great. So we will move on to safety evaluation. And the important thing for the safety evaluation is really just to figure out, are they at risk for suicidality? Are they at risk for homicidality? And then can you leave them alone in the community? So when we talk about assessing suicidality, the most important things here are, first of all, thinking, is it passive versus active? Someone who says, I wish I were going to wake up dead, may not be as high of a risk as someone who is actively suicidal, where they're saying, I have a plan and I have intent, and like I'm going to go buy a gun and I'm going to, go from there. The next important thing is the plan. So do they have a specific method? Have they really thought this through? Do they have access to that method? And then how far have they prepared? So for example, like looking at pills, have they taken the pills out? Have they, started like thinking about where they would do it, things like that. And then also, like we've said, intent was, what is the likelihood of them acting on the plan? A good question for this is asking, what did they think was going to happen when they went through this act? If they said, I thought that like maybe I'd go to the ED, that's obviously pretty different than, I thought I was not going to be here anymore. And then one of the biggest predictors for suicidality is past attempts. And so you want to also think about number of attempts, like how serious it was. One question I like to ask is, for example, if you had a previous suicide attempt, did that result in a hospitalization, or did you have to get more medical care after that? And then you also want to think about how lethal the attempt was, and then if they have been triggered for this in the past, like if it was through a breakup or something like that, and that's happening again now, then that would definitely raise your suspicion that this was at like a way higher risk. And then next you want to assess homicidality. And I think the best question for this is, were there specific targets? If someone says generally, like, I like want to kill a bunch of people, you you can feel a little bit safer. I mean, not that much safer, but you can feel safer knowing that there wasn't like one person that they had in mind. And then you also want to find out if they have access to weapons. And so, especially when you're looking at homicidality, another good thing to know is something called the Tarasoff law. It was this case that in certain states, you actually have to warn the target if you find out about it. And then you want to find out if they have risks to others. So if they're psychotic, especially if they have command hallucinations, or paranoia, then they are at a higher risk. It's really important to suss out command hallucinations for both suicidality and homicidality. With either, you're at a way higher risk, and you should definitely think about sectioning. And then finally, the question that you want to ask is, can you leave them alone? So if they have a history of self-injurious behavior, whether it's intentional versus impulsive versus compulsive, this is really important. For example, if it was just really impulsive, then maybe it was a fleeting thing and it was the heat of the moment, and they're feeling better now, then you can feel a little bit safer about potentially lifting a section or letting them go home, versus if it was very intentional. And then finally, you want to assess, can they care for themselves? Can they make their own food? Can they take care of their ADLs? Do they have some sort of shelter? Have they been able to take their meds? Do they know what those meds are? Things like that. One good question for this is, okay, if you were having a heart attack, what would you, like, what number would you call, or what would you do? Just sort of testing whether or not they could actually get themselves help if they needed it. You also want to look out for severe disorganization or catatonia, because that of course, makes them way less likely to be able to care for themselves. Going forward, it's really important, especially, so if you're sectioning someone, then you're sectioning them. You don't really have to get collateral as much because you're essentially ensuring that they are safe. However, if you are thinking about lifting a section or discharging them home, it's really important to get collateral and get some context. So talking to their family and friends to see if, you know, if their behavior has changed, if they're acting differently, things like that is important. You want to ask about recent stressors or loss. So if they recently lost a partner or even, you know, if someone's lost their dog, these can all be things that can increase the risk of that would make me think twice about letting someone go home. And then also if they're using substances or going through withdrawal, that's also really, really important because that can, you know, once this period ends or once they stabilize, it can actually be a lot, it can actually be very difficult to let someone go home unless you know what they're like when they're sober. And then for a safe outpatient plan, you want to document why they're safe. So, for example, what you'll see frequently is patients that come in through the ED who have chronic suicidality, and maybe it's their 10th or 15th time coming into the ED for this. But a really good question is, are they at their baseline level of functioning or their baseline level of suicidality? And these, of course, are not decisions that you'll need to make as a medical student, because this can be really, really difficult. But at the same time, what you are thinking about is, are they at an elevated risk compared to their baseline? You definitely want to also offer a safe discharge plan. So what you can do is you can offer partial hospitalization programs, intensive outpatient programs. You can try to figure out close follow-up with outpatient providers. Typically, you would need to document dates and times that the patient might see them. And then you also want to offer social work resources if you have a social worker working with you in the Psych ED. And then you also want to ensure that they have information on outpatient helplines. So 988 is national, and you probably have more local resources as well. And then if you're not sure, just call for help. What they tell us to do overnight, if we're really not sure and we can't confirm a safe discharge plan, is just to discharge them, or sorry, is to not discharge them, is to section them and make sure that they can just stay the night. They can either sober up or stabilize, and they can get reevaluated in the morning. Okay, any questions about that? Okay, so now
There's a question in the chat.
oh, is there? Sorry, I can't.
I can read it.
Oh yeah.
Peter Park asks, by sectioning, does that mean inpatient admission to psych ward/unit?
Yeah, that's a great question. So I don't know if this is different by state, but I'm in Massachusetts right now, and sectioning means that by law, you know, you cannot let them leave because you think that they would be a danger to themselves, to someone else, or they could not function safely in the community. That typically translates into an inpatient admission to a psych ward, but again, there are times where you section someone and they sober up, or they like the heat of the moment passes and they're able to stabilize again. And so then frequently what you'll see is that section will be lifted. But it can't, so the terminology will probably vary by state, but there is this general term that we use as psychiatrists. And it's definitely not it's definitely a very difficult part of the job. And there are definitely some times where I've sectioned people and I've gone home, I've thought, have I made the right decision? Because it's a really big deal because you're basically taking away their legal right to leave. But you know, I think that it's one of those things that you really have to think about, is this good for the person long term, and are you keeping other people safe and this person safe by doing it? Does that answer your question, Peter? Okay, I'm gonna assume yes. Okay, so next we're gonna talk about capacity. And this is let me actually start at this one. So Everything you need to know about capacity is from reading this one paper by Paul Applebaum. Sorry, someone just came in. I'm still at work. And it's called Assessment of Patient's Competence to Consent to Treatment. And this is, if you remember anything about capacity, just remember that you have to go back and read this paper. That's number one. And then number two is that any physician can determine capacity. So if someone from ortho is trying to consult you to get capacity, you can tell them that any physician can do this. Really important things are capacity can be decision specific and time specific. So that means that someone may not have capacity for what meds that they can take, but they can make decisions about whether they're DNR or DNI. And just because someone has a lack of insight does not mean that they have a lack of capacity. And we'll talk about this in a second. And then again, I'm going to stress this, any physician can determine capacity. So we can do a case really quick. I think we're still good on time. So this is a 67-year-old patient with schizophrenia who's brought in for hyperglycemia and found to have DKA. This is a real case. So that I saw last week. The team recommends ICU admission and insulin drip. And on the admission interview, when the team is doing the H&P, the patient says that he would like to be DNR. So on interview, the patient says, you know, I would like to undergo treatment for this insulin drip and ICU admission, but says, I don't want you blood-sucking vampires trying to revive me if my heart stops. And then he acknowledges that he has diabetes and that being in the ICU is really serious, but says, I don't want to get compressions because it looks like they really hurt. And then when you probe further, he says, Mom, tell them I don't want to do it. I've been suffering for 67 years. I'd rather die than be hooked up to the machines. This is definitely a case that I've seen a couple of times, obviously not exactly this, but there are definitely times where a patient comes in with schizophrenia and a lot of other teams will just automatically assume that they do not have capacity. And I think that this really goes back to some of our previous points where you're there to not only advocate for the patient, but also help the patient and the team collaborate to get them the best care. If we keep going, we just see that he has schizophrenia. He's mildly disorganized. He has limited insight and judgment. And then as we recall, lack of insight does not mean lack of capacity. So how many people think that he has capacity and how many people think that they don't? Raise your hand if you think that he does have capacity. I actually can't see, but is anyone raising their hands? It doesn't look like it. Okay.
Are you talking about capacity to for which decision are you talking about?
To be DNR. Great question. This is a tough one. Okay, so we'll just keep going. So if we apply Applebaum's criteria, and again, that's one of the few things that you have to remember is like how to look up this paper so that you can go back and know what questions to ask. But using Applebaum's criteria, can he communicate a choice? He clearly states, I don't want you to revive me. Can he understand information? He can repeat back the risks of not being resuscitated. He appreciates the situation, acknowledges that if his heart stops and he isn't resuscitated, he could die. And then he does have reasons about other options, and he is comfortable with this. And so I'm so sorry. This should be, he does have capacity. Sorry about that. So then you can go forward from there. And any questions about that? Okay, great. Well, thank you so much for the honor of being here. Feel free to reach out to me if you're applying to psych and are interested in coming to Boston. Feel free to call me or text me. I would love to hear from you. And I will turn it over to the next speaker.
All right, so thank you, Mary. I am next. I'm Jaclyn, and I will share my screen now. All right, so I will get started. Ooh. Okay, so I'm Jaclyn. I am a Manhattan native. I started in engineering before switching to medicine, did my training primarily at Stony Brook and Montefiore, and I'm wrapping up my child psych fellowship in a couple of months. We'll be going into private practice. doing a little bit of psychedelics that I trained in, and will be doing primarily children and adolescents for my work. Outside of work, I do baking, Pilates, travel, dancing, kickboxing, all of that fun stuff. So yeah, so just like a rundown of that I'm finishing my child psych fellowship, and I will be doing a lot of like ketamine and private practice. Next. So this is going to be a high yield section on PRN meds that I think is going to be very important for you guys to maybe take notes on. I remember going into ED or CL and just being asked to manage patients' agitation, anxiety, and sleep, and having to know some medications off the top of my head. So this is going to be an overview of some high yield meds that will be important, and I'm sure you all will pick it up along the way as well. Next. So typically scenarios that a patient's going to start yelling, you know, get out, I'm getting angry, I'm irritated. They might even like scream or curse at you, or at one of the staff. You arrive on scene, and what do you do? Next. So the type of codes that you might have, they really vary by hospitals. I've been in multiple hospitals where it's like code M or code Panda, or even they'll scream your unit number and you have to show up to be there for the team. We typically will start with de-escalating the situation. Really, the number one thing is always to see if there's other interventions you can use to diffuse the aggression, and see if you can offer some sort of like comfort items, snacks, you know, de-escalation techniques that are not utilizing meds. The other important thing is you really want to prioritize your safety. Your safety, the staff's safety, and the safety of other patients is going to be really important. So sometimes that means, you know, isolating the area and just keeping it as small as possible, and just having the primary patient and a couple of staff members there. PRN meds we're going to talk about in the next slide. And what's going to be important, that's going to be a very brief overview today, is the type of holds and restraints that you may end up doing in the hospital. There's manual hold, which is going to be staff members physically holding the patient a certain way that doesn't, that complies with like OMH rules. And there's also restraints, which is essentially using like neoprene to tie down the patient. So what you have with the 2 arms and 2 legs, that's a 4-point restraint. And if you put a band around the neck, that's going to be the 5th point restraint. Not every hospital has this. So when you start your, you know, residency and rotations, I would check, you know, what type of restraints your hospitals have. If this is a CL consult on the medical floors, you might have to explore a little bit more in terms of why they're agitated. It may be a little bit more focused and, you know, a little bit easier to figure it out if they're on the psych unit. But if they're on medical, you really have to explore, is this like a sugar problem, electrolyte disturbance? Is this Wernicke's? Are there neural issues? Is this related to other medications or substances? And we see this a lot in like steroid patients who are receiving steroids for other reasons. And then also the other, you know, thing is delirium. If there's any issues with like oxygen levels, or if they're in cardiac shock, you really want to be on top of all of that before jumping into this being a purely psych patient. A lot of medical teams may sometimes be quick to consult psych whenever there's any form of agitation. And so it's really a collaborative like team effort to figure out what's going on with our patient. Next. All right, so the PRN meds that are going to be really, really important are listed below. These are just some of the ones that are common in a lot of the hospital facilities. When you hear 5 and 2, that means 5 Haldol with 2 of Ativan. 5-250, you're adding a 50 milligram of Benadryl. And this is also called B52, or they'll say plus Benadryl. 2 and 2 is another combination that you might hear a lot of. It's 2 Ativan and 2 Risperdal. Zyprexa, we typically like to give because it comes in oral and IM versions, so 5 or 10 milligrams. And sometimes if a patient is already doing well on a specific antipsychotic, like say they already are getting Zyprexa, then you want to just stick with the same medication and give an extra dose without hitting the max dose. Thorazine is one of my favorites that I give for patients who are maybe younger or have some sort of spectrum disorder. And I usually start with 25 to 50 milligrams. What I have on the right side is essentially IM and oral agents that we typically will use. Combinations are really vary at different facilities, but if you want to screenshot this, these are some good starters for medications that you can use for agitation and aggression. Next. So the first thing you always have to do before you give any medications, after de-escalating the situation and realizing that you have to escalate to medication use, is always check allergies first. This is one of the main ways that someone can get sued for malpractice, and it's not checking allergies and then giving them Thorazine when they have an allergic reaction to Thorazine. So you always want to check allergies first to the medication, allergies to any medications before you give the patient any meds. You want to monitor vitals, do a full physical face-to-face and appropriate documentation. Documentation also varies heavily in different hospitals. You may have to fill out like an official form, you may have to document on the computer, and a lot of facilities will have their own 24-hour rule where you have to submit documentation, and your facility may get dinged if you don't. So I would go over all of that with your residencies just to be prepared. You want to get EKG as well, because a lot of these medications can get a little funky with the QTC prolongation. So you want to just check that, any sort of like cardiac health. And the main thing that I'm going to, sort of emphasize is never give IM Ativan and IM Zyprexa together. So never give IM Ativan and IM Zyprexa together. This can cause respiratory depression, and we typically want to wait, I say like 30 to 45 minutes before we would even consider giving the other medication. On the right side, I have the different agents for like different benzos and the potency. You're going to be giving different cocktails of these as well at some point. And the important thing is that they have different potencies. They have different, some of them are short acting, long acting. And so if you look at this chart, you'll see that Xanax is essentially 2 times potent compared to Ativan. So when you're giving benzos, you really want to be careful and aware of like what you're giving, especially in the case of like substance withdrawal, but also for other reasons, other indications. Next. It's okay to also take a pause and debrief the situation. So if something happens and everything escalates very quickly and maybe someone's hurt or someone gets called out or someone gets spit on, it's okay to take a pause at the end and check in on each other, check in on staff. That brings up the morale whenever these situations happen, because they can be very scary. They can be traumatic for, staff who've never experienced this. And so it's always good to come in with a collaborative, teamwork mindset and check in on each other. So the number one thing I would say is before you officially start, your rotations, residency, really clarify your protocols, know what you have to complete for documentation, what times you have to see the patients, face-to-face evals, essentially doing a very quick physical on them to make sure that they're okay before and after medication administration. Next. So other common PRN meds is, what we went over was more for agitation. For anxiety, typically I would evaluate what meds they're already on and see if I can just amplify what they already have. So if they're already on something like Seroquel, I might just give them another baby dose of Seroquel to help them with that. Benzos, we do give for panic attacks and, catatonia and other things, but it's usually not a first line. We're not going to start like a brand new benzo on someone. We typically stick with off-label antihistamines or like off-label medications like Lyrica, gabapentin. And then Buspar, I've had many different anecdotes of like Buspar either working or not working. Typically, if I start Buspar, I will titrate it up very quickly to 30 milligrams twice a day. So we're going to move on to sleep now. Okay, next. Okay, so sleep, it really depends on what setting you're treating sleep. If it's outpatient, you have more of a stable patient. You want to evaluate other mood symptoms that may be impacting sleep. Is it depression, anxiety, PTSD, something else that's going on? Because then that's going to also drive your treatment. If it's PTSD and nightmares, you might want to give Prazosin instead of something else. And you want to really go over sleep hygiene, because sometimes structural changes is going to be more important in the ecosystem of building an important sleep routine than any medications you can give. If it's emergency department, you really want to assess, are these medical issues? Is this acute, chronic? Is this pain related? Some people come in with chronic pain symptoms and they really just can't sleep. And we can load them up with like psych medications, but if the pain isn't addressed, they're really not going to have a good sleep. For inpatient, it's always going to be assessing comorbid medical issues as well, or if it's a primary psychiatric concern. And also, people will struggle with adjusting to sleeping in a hospital bed, especially if it's very unfamiliar, and that could be another reason as well. And every time you get consulted, you really want to do your due diligence with medical issues, agitation, delirium, is it sundowning, and is it pain? Next. So this is my go-to outpatient sleep hygiene. These slides will be shared with you guys, but this is typically what I go over with my outpatient folks about like what I would recommend, what I wouldn't. This is definitely more of a long-term buildup, but I think it's so much more sustainable than just taking medications and relying on a pill essentially. Next. So inpatient CL, a lot of the hygiene tips really apply to inpatient side. You want to cluster care. I've seen many patients struggle with sleep because they're being poked multiple times or they're being woken up for vitals or something. And it really comes down to speaking with the medical staff to see if they can do everything in one shot so that they can let the patient rest and be at peace. I like to, go over like keeping the shades open, bright lights and everything, music on, have familiar family members be in the room. And then at a certain point, like 8 p.m., everything goes dark. We provide, earbuds. We try to create like a very peaceful environment for patients to want to go to sleep. And it's really building this sort of routine for them so that they don't struggle as much with this ecosystem that we're trying to build for optimizing their sleep. So that's really the main thing I would say. And then sometimes there are different consultation services. For us, we have like something called Child Life or even PTOT that would help patients stay active and be a little bit more like mentally stimulated during the day so that at the end of the day, they're more tired and they want to go to sleep. Next. So there's so many meds that I do go through with patients for sleep. If it gets to the point where we try these sleep hygiene tips and we do this like ecosystem to optimize sleep and they're still not sleeping, I do end up going towards melatonin first. And my go-to with melatonin is a very low dose, 1 to 3 milligrams, and giving it hours before they have to go to bed. A lot of patients will take it an hour or half an hour before they have to go to sleep, and that's just not enough time in general. Magnesium, there's some studies out there that magnesium glycinate can be helpful for sleep, and some people, vouch for it. I haven't seen more like meta-analyses, but I also sometimes recommend magnesium with some of my younger patients. But other ones that we do is like Benadryl or Vistaril, which is also antihistamine that we also give for anxiety. Sometimes it might mean that your SSRI or your SNRI is too activating at night. So I'll actually move the bedtime dosing to the morning, and that can also help with sleep. If it's anxiety based, I tend to go with any of the, gabapentin, Buspar, Remeron, Seroquel. And then if it's more depression based, I tend to lean more on trazodone, doxepin, and suvorexant, which is one of the newer sleep meds. And then really, really, really last resort, I rarely do this, are benzos and Ambien. So if a patient is like really struggling with jet lag and they can't sleep for like 2 weeks and they're asking me, I'll be very clear that I'll give just a few doses, and I'm not planning on refilling those meds for them. Okay, so we're going to talk about medical emergencies in the psychiatric realm, and acute dystonia is one of the most important things that we'll be covering here. Next. Okay, so EPS. So this is like one of the big things that can happen if there's dopamine deficiency in the nigrostriatal pathway. We see symptoms of this, similar symptoms in Parkinson's disease when there's a loss of dopa neurons in the pars compacta. And then when we use antipsychotics, there's a huge blockade of D2 receptors in the nigrostriatal pathway. And that's like 3 points on your board exam, that last piece right there. And we can go to the next slide. So yeah, so this is really drug-induced movement disorder, and we typically see this more in the first generation antipsychotics. So I'm talking about things like Haldol, Thorazine, and fluphenazine, and also risperidone from the second generation. These are just higher risk, and so we really want to pay attention when we give these medications. These are 4 of the main, subtypes. Essentially, there's pseudo-Parkinsonism, which are some of the symptoms that we see in Parkinson's. There's acute dystonia, which is where you see like grimacing of the face. Sometimes you see like involuntary upward eye movement, spasms of parts of the face, and laryngeal spasm. This is probably the most important, emergency, because if you have laryngeal spasm and essentially laryngodystonia, that can impact breathing, and you really want to be on top of any sort of breathing issues that patients can have. Akathisia, you may see like restlessness, trouble, staying still. Sometimes it affects sleep. So sometimes when patients are aggressive or agitated, you want to check that they don't actually just have akathisia, because that can be, treated separately. And then lastly is tardive dyskinesia. You'll typically see, movements of the tongue, lip smacking, sucking, chewing motion. There can also be involuntary movements of other parts of the body as well. So this slide is more of to show you the timeline of each of the symptoms. Acute dystonia really happens, quickly. I've seen it happen, minutes to hours even after treatment. So that's like the first one that you really want to take a good, snapshot of this to be able to pick out if you do see it in a patient. And then pseudoparkinsonism and akathisia, days to weeks of medication treatment. And then tardive dyskinesia is more of the long-term symptom that may happen from taking the medication for a while. Next. Okay, so I spoke about acute dystonia already. So it's involuntary muscle contractions. This is a picture of someone with acute dystonia, and it's essentially an imbalance of the dopaminergic and cholinergic activities. You do want to do range of motion. You really want to check breathing, swallowing, and speech. Those are going to be very telling if there's any concerns of acute dystonia. And sometimes we'll do, vaccination history and blood tests just to make sure it's not tetanus or any sort of electrolyte deficiencies, which can also result in the same sort of picture. This is potentially life-threatening because of the breathing component, and you really want to check for the airways. In this case, if you do suspect acute dystonia and there's a high suspicion, you want to give 1 to 2 milligrams of IV benztropine plus 1 to 2 milligrams BID for 7 days, and that's the treatment for this. Next. Okay, so the next big thing is NMS. I'm sure you've heard of this from like board studying. This is life-threatening, and the main things you want to look for are altered mental status, fever, rigidity, and dysautonomia. So you're going to check vitals to the highest point: blood pressure, temperature, heart rate. This is really what leads to mortality. It's the fact that the dysautonomia is not being managed well. Incidence is 0.02 to 3.2%. And mostly common in first-generation antipsychotics. But there are other medications that can contribute to NMS. So there's an interference in the dopamine pathway again, and in this case, one of the big things is you might notice the CK is above 1,000, and that's one of the like lab symptoms that you will notice. There's tremors. There's a lot of like changes in the electrolytes imbalance as well. You'll see rhabdo, and so this is a big thing that you really want to be on the lookout for if you're concerned about a patient presenting with altered mental status, fever, rigidity, and messy vital signs. Next. Okay, so what I have here is more of the DSM-5 criteria. It's essentially what I like shared in the last slide, but this is more of a breakdown of what would characterize, DSM-5. You have to rule out, infectious, toxic, metabolic, and other neurologic causes that can relate to this. And yeah, you can have urinary incontinence, diaphoresis, basically sympathetic nervous system lability sums it all up. So the differentials with NMS include serotonin syndrome, which we'll go into next, malignant hyperthermia, malignant catatonia, and drug-related syndromes. We're not going to go through everything just because we don't have enough time, but we're going to go over serotonin syndrome next. Oh, so in terms of treatment, you want to stop the offending agent. And that can also mean restarting a Parkinson's drug if you had recently taken it off. You definitely want to protect the airway. If that means intubating, then you have to intubate. Supportive care, you want to, keep patients cool, cooling blankets, fluids for rhabdo, address the blood pressure, electrolytes. And you can give benzos in this case. Ativan 1 to 2 milligrams, IV, Q4 typically works. There's some varying clinical data on dantrolene, bromocriptine, amantadine, which we use for some of the other differentials like malignant hyperthermia. It really varies, and some places may recommend using it as well. DVT prophylaxis and ECT is also there. Mortality is quite high, 5 to 20%, so you really want to be on top of this if you suspect NMS. Okay, so serotonin syndrome. There are many different criteria for serotonin syndrome. This is just one of them, but this is pretty common to hunter toxicity criteria. So typically it's history of recent exposure to a serotonergic drug and at least one of the following, which are different types of clonus, agitation, diaphoresis, tremor, hyperreflexia, or hypertonia. There are a lot of meds that can contribute to this, and I put them all, on the right side, but I've seen, sometimes patients have serotonin sensitivity in general. So sometimes even putting someone on SSRIs with dextrom and thorphan leads to them like experiencing some sort of symptoms. So they don't have serotonin syndrome, but you do want to assess patients who are on multiple medications that do have a serotonergic effect, and just be on the lookout for any of these symptoms. And yeah, we can go to the next one. So in this case, you do also want to remove the offending agent, give any supportive care, manage agitation, and in this case, you can give benzos. And then you also want to give, a 5-HT2A antagonist, typically cyproheptadine, 12 milligrams PO, and then 2 milligrams Q12 if the symptoms continue. You want to manage the auto instability and hyperthermia that can come in this. Next. So this is just a chart that compares all of the different emergencies that we typically may see on the psychiatric side. Take a look at the onset, they vary between NMS and, serotonin syndrome. The vitals are all pretty wacky in all of them. So that's typically not what I would use as a way to like differentiate them, but you'll see even like similarities with anticholinergic toxidrome, which you might see in like the medical consult side. And yeah, I think this is a great chart to try to remember if you're on the CL side or even inpatient psych unit and your patients are on multiple different medications or they have a lot of medical comorbidities that may present themselves. And that's all for me.
There's a question in the chat.
I typically do stick with Zyprexa IM in general. And I think there's some like balance with, EPS risk, but also if it is if it is like an older patient where you're giving a very low dose, like say like 0.5 milligrams of Haldol every, Q1 to 2 hours as needed. I think it really doesn't matter for me personally, but I typically stick with Zyprexa for like younger patients, and then I do either for older. And I think the other thing with PRNs is that you're also going to notice as you work with different attendings and different staff, people have different personal preferences based on their anecdotes of like or their own like treatments of patients. So you'll kind of learn like what fits with your preference the best, like what effects you've seen on your patients, and you can sort of like build your own sort of like cocktails as you do more and more training.
Hi everyone. So you can call me Pooja. I grew up in Cleveland. I'm currently a third-year resident at MetroHealth, which is associated with Case Western. My interests are medical education, advocacy, safety, and cultural psychiatry. Once I finish residency, I'm planning on pursuing an inpatient job in an academic center. And then outside of work, I like to plan parties, especially like themed events, like watching movies, hanging with friends, and I'm a big foodie, so I always like to find new restaurants or try out different places. And I really want to welcome all of you and always feel free to ask any questions or to stop at any point if anything is not making sense. So we're going to start with the mental status exam. So I would start with, what is the mental status exam? I think it's one of the biggest differences in our psych rotation compared to the other specialties. I would say, when I was learning about it, people would say it's like our equivalent of the physical exam. Also, I remember an attending telling me once, and it always stuck, that the mental status exam is basically if you would ask someone to play this person in a play, what would be all the things that you would need to know about that person? And so it covers a range of mental functions and behaviors at a specific point in time. And a lot of it is gathered from informal observation. In terms of it being a specific point in time, I just want to say that different people will have different evaluations of the mental status exam, and especially at different times of day. And so it really only um, is only suitable for that. It's like time that you examined that patient, and it can be completely different the next day. So how to start it? So I would say the first thing that in most mental status exams that we cover is appearance and behavior. So this could be like, age, sex, race, body build, posture, eye contact, how they're dressed, how they're groomed, and other distinguishing features. I always tell my medical students that, how would they remember this patient? Or if someone is looking at your note and they're taking over, what would be some things that are particular to this patient? So that would be like tattoos, if they have different color hair, they wear glasses, if they have a beard, things like that. I always put like, if they use a cane, if they have like a wheelchair, if they're an amputee, I definitely put that in there. How do they appear compared to their age? So do they appear younger than their stated age, older? And I think especially like for really sick patients, some of them do appear much older. And so I do think it helps with our assessment of the patient. How is their attitude towards the interviewer? So their attitude towards you. Do they display like psychomotor agitation, psychomotor retardation, abnormal movements? How is their gait? Any catatonia? And so I also want to point out a common mistake that I think people make, or that I've noticed, or attendings have pointed out to me, is there's psychomotor agitation and then there's restlessness. Do you guys feel like those are the same things, or do you think they're different? And then if so, how are they different? Anyone have any thoughts on that? Or
I feel
any
like I
Oh,
feel
go
like
ahead.
you were trying to say those are different things, but I cannot confidently tell you if they're different, how they're different.
Yes, so you're picking up what I'm putting down. So definitely they are different. But people do often confuse them. Any like guesses about like, how you would define like psychomotor agitation or differentiate it from restlessness? So I would say like Jaclyn had mentioned, restlessness can be a side effect of our medications. I would say like in terms of psychomotor agitation, I don't like a person doesn't have to feel restless in order to be agitated. I would say like in terms of agitation, like these are signs for potential violence, for potential aggression, for potentially an unsafe situation. And so they're not the same. But like Jaclyn had mentioned, this can also, if you notice someone is restless, this can lead to violence as well. But it's not the same thing as you think of like, okay, this person in this moment is probably going to hurt me in most scenarios. So that's how I usually describe it to my students. Um, I would think of like psychomotor agitation as I'm worried that they would hurt me, whereas like restlessness, like you can be pacing around the unit, you can be tapping your foot, moving around, and not be, so angry. Whereas like a psychomotor retardation or psychomotor slowing, I would say, a way that I like to say is like literally everything is slow. They talk slow, they move slow. It can be seen in like schizophrenia and depression. It can be seen in many different things, but I think once you see it, you'll never forget it. Some other things I wanted to mention in terms of like grooming and what they're wearing. I think that it also tells you like how well they're taking care of themselves. And so I do like to put if I notice stains on their shirt. A common one that maybe is not as common anymore, but like when everyone, had to wear masks, if their mask was inside out or their mask was upside down, I used to put that on. It was one part of the picture. So I think all of these features are important to document or at least think about when you're thinking about the assessment of your patient. The next part would be speech. And so speech can be divided up into many different components. I would say to always document, like, rate, tone, rhythm, and volume. So, how fast is the patient talking? How loud are they talking? Are they really soft? Do they come at you with like an irritable tone, with a condescending tone? How much are they talking? Are they hyperverbal? Are they not talking too much? Very limited words, one word answers. How is their articulation? Are they spontaneously talking? Do you have to get all of the information out? Like, really pulling teeth, like what's it like? And then is it pressured? So are they putting emphasis on every word that they're speaking, or are they speaking like how we all normally speak? So these are things to think about, especially when you're describing speech. And then thought process. So speech is how they talk. Thought process is more like, what are they talking about? So does it make sense? Are they talking about the same topic over and over again? Are they perseverating? Does it seem like they have some thoughts, but it's hard for them to verbalize it, or something is blocking it? How are they connecting each topic? Does it make sense how they're going from each topic to topic? Do they not answer like the questions that you ask? Does it make sense how they're going from topic to topic, but has nothing to do with what you asked? I'm just gonna see. Yeah. So like there's all different types of association. So there's like tangential, which is just like the word says, like they're going off on tangents. So you understand how they're going from topic to topic, but has nothing to do with what you asked about. Whereas circumstantial, they go off and they talk about something else, but then they come back to the topic at hand. And so I think of it like a circle. So, they talk about something else, but they come back. Whereas loose, you have no idea how they're moving from topic to topic. Tight is like how we all normally talk. We understand it. It makes sense for the context, for the topic at hand. And then there's another association called concrete. With concrete association or concrete thought process, that means that there's no abstract thinking there. They're very literal. You ask them, how was their night? How did they sleep? And they will say like they slept, but nothing more. Like it's very basic type of thinking. And then what are they talking about? So we talked about, how are they talking? We talked about their connections, but now like what is actually the content? And so in terms of your mental status exam, I think it's important, or at least how I was taught it, to divide it up into perception, delusions, and safety. So in terms of perception, this is how the patient views the world. So this is where you put in hallucinations. This is where you put in illusions. This is where depersonalization, derealization is. And so any types of hallucinations would go here. And you want to document like what is the hallucination of if they tell you. Is it command in nature, meaning it's telling them to do something? So like I like to specify like if they're having an auditory hallucination and they're hearing a voice, does the voice have a name? What is the voice telling them? Is the voice telling them to kill themselves? Things like that. And then an illusion is like they misinterpret, like they see something and it's actually a spoon, but they see it as a knife. So that's something else to think about. And then delusions. Does anyone know the definition of a delusion? So it's a fixed false belief. So it's different from ideation. Basically, in ideation, you can be talked out of, whereas a delusion is fixed. And then there's bizarre and non-bizarre. So non-bizarre means that it's possible that the delusion is real, that it could happen in our reality. Bizarre means it couldn't happen. So an example would be like, let's say they said that they had these magic powers. For all intents and purposes, we're going to say that's not possible. Whereas a non-bizarre, I've had patients who say that they can't poop or pee. Technically, they could have like some disorder happen that prevents them from urinating or defecating. So it would be a non-bizarre delusion. And even more specifically, that delusion would be characterized as somatic, as it has something to do with the body. I think when you're starting off in your medical school rotations, I always tell my students that I don't expect you to know the name of the delusions, but I do expect you to be able to describe the delusion in your mental status exam and to me when you're telling me about the patient. I think the delusion that I would expect students to know is paranoia. And we'll go into this a little bit later when we're talking about questions to ask. But paranoia is definitely a delusion that is really common and that we often see on our units or patients coming into our clinic. Once you get into psych residency, I would say it's important to remember these types of delusions, and there's so many out there. The next part would be safety. And so I know my colleagues had already touched upon this, but I would just say another term that we use is something called passive death wish, which is something like, if I were to go to sleep and never wake up, I would be okay with it. Or if a bus hit me and I died, that would be fine. So that's different from active suicidal ideation or active SI. These patients, they don't want to live, but they're not going to do anything to hurt themselves at that moment. And also differentiating it from self-harm. So I have patients, and you will definitely have patients that they want to hurt themselves, but not with the intention to die. So it's important to clarify these when assessing a patient. And then, as my colleagues had said prior, you want to make sure that you know about intent and also about plan. And so I would also document that in your mental status exam. Next is mood and affect. So these terms often get confused for each other. Mood is how the patient says that they feel, and affect is your view of them, your assessment. So I usually just ask the patient if they can define their mood for me. And whatever they say, I put in quotes. So even if they said like shitty, I would put that in quotes. There's so many different terms that you can use. You can say like, they could say they're irritated. Let's say they don't give you never ask them, what were they telling you? What were the feelings they were expressing? And then in terms of affect, is what they're saying congruent or the same as what you think that they are expressing? And how big is the range of the emotions they're showing? Is it appropriate? So, I have patients, they'll be talking about like how they wish this person died and this bad thing happens to that patient, they're laughing. That's clearly an inappropriate affect. And another thing to think about is stability or lability. So another thing is like, do you know what you're gonna get? So like someone who has labile affect, you never know what you're gonna get. They're laughing one moment, they're crying the next moment, they're angry the next moment. So these are all things to think about when you're trying to describe affect. I also had mentioned alexithymia, which does anyone know what that means? I see a chat, but I can't see the message. Oh. So you're thinking of dysthymia. So good guess. So alexithymia means that they have difficulty expressing their emotions. So next part is cognition and sensorium. So this is where your A&O times 3 questions or A&O times 4 questions come into play. Are they alert and oriented? What's their level of consciousness? What's their fund of knowledge? What's their memory like? So in terms of fund of knowledge, we're going to get into how you ask that, but you want to see like, is the knowledge that they know or describing the same as you would expect from their position? Or their like current situation, and then different types of memory. So we have recall, remote, recent. I usually remember this as recall is like working memory, recent's like short term, and remote's like long term. Then we have judgment and insight. So judgment is the ability to assess the situation correctly and within societal norms. I would say like in our units, you usually see this if they're taking their medications to be fair judgment at least. And insight is awareness of the situation. So most commonly in the psych setting, this means like, are they aware of their illness? I would say different ways to test this is, what do they think is going on? That kind of gives you a little bit more, you know, insight into what they're thinking or what they're feeling about the situation. Judgment, another way that I was taught when I was a medical student, is if you were in a crowded movie theater and you were the first one to realize that there was a fire, what would you do? Or like you're walking on the street and you find a wallet, what would you do? And not doing anything in terms of the wallet situation doesn't mean poor judgment. How many of us would actually do anything in that situation? But if they said they would take the money, they would go spend all the cards, that's not a good judgment. So those are things to think about. So now let's get into must-ask questions. So if any of you, I'll share my email and my phone number. I always share this with any of my students on my first day, and I used to print out these questions and take it with me to my psych rotations, and even when I first started intern year. So let's start with, how do you start? So I've been taught different ways, and I think you all have to realize, what's your interview style. Some people just want to get this out of the way from the start. Some people will ask this more in the social history. So you want to know, like, what's their age, what are their pronouns, their marital status, living situation. These are just getting some background data on them. And then, of course, you want to know the history of present illness. So you want to know their symptoms, their onset, when did they start, what was going on that led to that ED visit or that inpatient admission, or prior to them coming into the clinic. If they're coming to the ED, who brought them in? That's really important to know. Did they bring in themselves? Did the police bring them? Did someone call? Because it really gives you more information about the situation and how bad the situation was. What are the stressors going on in their life? You definitely need to ask about suicidality and any other potential risks. In terms of like onset and progression, events leading to admission, symptoms, all of that, I think really just leaving it to open-ended questions will answer a lot of these. You don't have to say, like, I would definitely not say, like, what are your symptoms? They're not going to know what you're asking, and they're probably going to say nothing. So I think it's all the skill of the psychiatric interview, which takes time to, fully be able to do. But I would just leave it open-ended, and usually they answer all your questions or the things that you need to know, and then you can just hone in on the things that they might have missed. So just like any of the medical specialties, we also have a review of systems. So I used to have this printed out, and so that I could easily refer to it. And then as you keep doing it, it'll come to you and you'll remember it. So I'm not going to spend time going into detail on each of these, but this is important to know because you want to make sure that you're covering all your bases the first time you meet a patient. I had said we would come back to paranoia. So I never ask a patient, do you feel paranoid? Are you paranoid? I never say these things. Because a lot of them would say no. And people who are truly paranoid and don't have much insight, they're never going to admit that they're paranoid. So I usually ask in different ways, like, do you feel like people are following you, monitoring you, wanting to cause you harm? Are they watching you? And it's important to think about the context of the situation. For example, in the inpatient unit, people are watching them at all times. So you want to think about it and think about, like, what is at that level of, like, delusion. And then even in terms of auditory visual hallucinations, I never ask a patient, do you have hallucinations? I always ask in other ways. I ask, if they're in a room alone by themselves, do they ever hear someone talking to them? Or do they ever hear whispers or sounds? And nobody else seems to hear these things, even when they are around people. Or do they see things? Or I like to say about common ones, like, common one is like shadows. So I'll ask about that. Another one is like static or whispers for auditory hallucinations. So I usually like to ask about that. And then when you're going over all these symptoms, you want to know how long have they been going on for, because that will give you key into what exactly your diagnosis is or your differential should be. Then you should make sure that you ask about past psych history. So you want to know about prior diagnoses, prior provider, the prior psychiatrist, prior experience with therapy, prior therapists, if applicable, their prior case manager, prior hospitalizations. What was it for? How long were they there? Where was it at? You want to know all these things when you're first meeting the patient. Any prior suicide attempts, self-harm episodes, how did they do it? What was the means? I put common areas because I like to know personally, like if they self-harm, are they commonly doing it like on their thigh, on their arm? Like I like to know these things. I want to know, do they hide them? Do they tell anyone about any of this? I've had multiple patients tell me they had suicide attempts, never were hospitalized, never told anyone that something happened before they actually died. And then you definitely want to know about prior med trials, any side effects with those prior medications. How long were they on it for? Because was it an effective trial? Were they on it long enough for it to be an effective trial? I like to know doses. Usually my patients can't answer this many details, but as much as they can, I do like to ask. And then what are their current medications? What are their current doses and how do they take it? And we definitely want to know about substance use. So I always, when I ask patients this, I'll be like, do you use any drugs? They'll tell me no. Then I'm like, do you use any weed? And they're like, yes. So I've had a lot of patients who don't consider weed to be a drug. Or if I ask them, you know, how much they drink, they'll tell me they drink, but they don't consider that a drug. And same with smoking. So I think it's important to specify a little bit more. And then what is their prior experience with treatment, with rehab, with detox? Have they been to those? When did they start using any of these substances? How much did they use at their most? How much do they currently use and their frequency? Like how often? Have they ever had any signs of withdrawal? What is the time of their last use? So especially for some of these that are more life-threatening, you want to definitely know last use, and especially in terms of withdrawal. So like, for example, with alcohol, with benzos, things like that. And you would do this for each substance. As you go on further into your like training, you'll definitely learn like how to assess for substance use disorders. So there's an amount of criteria for different specifiers. And so as you keep doing these interviews, it'll become like second nature to you. Then you definitely want to know still about medical history, including like current medical conditions, current medical medications, drug allergies. Do they have a PCP? Have they had any trauma? I definitely want to know about head trauma, concussions, seizures. These are all things that we want to take into account, especially when we're thinking of prescribing them a new medication. And then we want to know about their family history. So, in terms of psych history, what were their family psych diagnoses? Did their family try any meds? What meds were they? They've seen that, you know, often usually the medications that did well for other family members could be the medication for that patient. I'll ask about this, and people will say, yeah, nothing, there's no psych history in the family. Then I'll say, what about addiction? And then it'll tell me so much more, and they don't think about that. Or I have a lot of patients that don't think about that as psych history. And so I like to specify that. Or I'll ask like anyone in the family attempts suicide or complete suicide, and then there'll be someone. So I think it's important to specify all of these things and who exactly was it. So they say their uncle, like, is it their mom's brother or their dad's brother? So I always want to specify this. And then any other medical conditions in the family. So I especially want to know if there's neurological conditions or, you know, cardiac issues. And then social history. So where were they born? Who raised them? How was their childhood? How far did they go in school? So I always ask for education, how far did they go in school? Because I find it to be less awkward than to say like, hey, did you complete high school? Did you go to college? I find it to be like, you know, you're not, some people can take offense to those types of questions. And so it's just easier to say, how far did you go to school and go in school? I also like to ask, like, did they have any special classes, especially for those patients that I'm suspecting some sort of disability? And what were those special classes? Did they have an IEP, like 504, things like that? And if they're, I would ask, like, are they married? Are they divorced? You know, who do they live with? who's at home, who are their supports, any military past, any legal issues. I do like to ask about religion just to know if that's something that's important to them. I have some people say that, you know, they're not religious, but they're spiritual. If they tell me they're religious, I like to ask about like what their religion is. I think it does give you a picture into who they are. And then trauma and violence. So I always like to, it's very important to know about their trauma history, and you don't need to go into details on an initial assessment, but you know, asking if there's history of like emotional, physical, or sexual abuse is really important to know. And if so, do they going into those psych review of systems in the PTSD part? And then if this is a patient that now you've been following, this is the second day you've seen them or you see them every day, here are questions you should be asking them every day. So this is more applicable to like an inpatient setting. But even in like a clinic type setting, I also ask a bunch of these questions. So I want to know, you know, how their mood is, how have they been sleeping, how's their appetite, how's their anxiety, and you know, it's okay to also rate their anxiety, just like how we rate pain. You can say like anxiety with 0 being no anxiety to 10 being the worst anxiety in their life. How would they rate it? Especially for those patients who are not the best at describing what they're feeling. I've noticed using that rating system can be really helpful, even with patients who every single visit they're telling you they're the same. Using that rating system can really let me know if we're doing anything that is helping them or not, or making it worse. I definitely want to know about medication side effects. I want to know if they've been attending groups, have they received any visitors, who they've been talking to. And at my institution, like I can see a lot of these things. So if they went to groups, it's documented. So I always like to know like what they say compared to what's documented, because that also tells me things. And then of course, suicidal thoughts, homicidal thoughts, auditory visual hallucinations. And then if you know they came in for a specific reason, you want to make sure you're addressing that. So if they came in saying they can't defecate, you want to be asking that about every day, or like, you know, seeing if they spontaneously bring it up. And then when I was first training, I learned about this like mini mental status exam. I'll say like now I really don't do this unless there's specific questions that I think would be applicable. So in terms of like not knowing abstract thinking, I would ask about like what's the similarity between an apple and an orange? In terms of fund of knowledge, I would ask about like who's the current president? Um, if you're testing their memory, like who was that before them, before that? And thinking about like, would that person, should they know who the current president is? Most of us would, right? Some other questions to ask are like, what, like name 5 cities in the US. That's something you think most people could answer. And then going back to the top of like the date, these are orientation questions. So I have people who'll tell me, I don't know. And I'll say, guess the year, your best guess. And I really try to push them on that, because most of them can at least get the year and the month. And then where are we? What type of place is this? So those are types of things. In terms of like serial sevens or spelling world backwards, that's assessing attention. So those are other things that you can be asking. Then I will finish up by quickly touching on delirium. So I just want to start this with saying that delirium is a big topic that I could talk about for much longer than the time that I'm going to be talking about today. So this is just touching the surface. And so this is really a common consult or a common reason that psych is called. So I think it's good that we'll be touching on this. So according to the DSM-5, the criteria includes disturbance in attention and awareness. It develops over a short period of time and fluctuates. It has an additional disturbance in cognition. It's not accounted for by other neurocognitive disorders. It's caused by a general medical condition, and it can be of multiple etiologies. And so in the DSM-5, it's classified either as due to another medical condition, substance intoxication, substance withdrawal, delirium due to multiple etiologies, or induced by a medication. And with the DSM-5, there's further specifiers. Is it acute? And so this would be like a short time period. Is it persistent? And delirium can go on for several months. So it's something to make sure that you're taking a note of. And then is it hyperactive? Is it hyperactive? Or is it mixed? So I think it's important to think about what are some synonyms for delirium. All different specialties use different terms, but they all mean the exact same thing. So in psychiatry, we often use the term delirium. In a lot of medical settings, they'll use like altered mental status, but it all means the same thing. So just thinking into account in neurology, they'll use like encephalopathy. So these are things to think of, but this is what they're referring to. And then thinking about like, why is it important for us to learn about this? This is something that's commonly unrecognized. ER physicians miss about 83 to 87% of cases. Usually it results in a hospital admission 14 to 24%. And nurses recognize it more frequently than physicians. So it should always be considered when there's an acute or subacute deterioration of behavior, cognition, or function. And often a lot of the cases are preventable. So I just wanted to point this out. This is about prevalence of delirium. You can see that's really prevalent in terminally ill patients in the ICU. But you can also see with like burns, with like post-op of the cabbage. I also see like post-op of like fractured hip. So these are common places that you might see it, but these are also places that you should be keeping it on your differential. So again, why do we care about this? So delirium leads to increased mortality, almost 25% more chance of death. And the adjusted risk of death is twice as compared to people who don't have delirium. It also results in increased morbidity, so poor functional recovery, possible future cognitive decline, increased risk of complications, increased nursing home placement, increased cost, can also lead to depression and PTSD. So I've had multiple patients who they became psychotic in their delirious state, and they might have hurt some people. And when they come out of the delirium, they remember everything. And that's a really scary thought, to think that that was the state that you were in and that was you doing all of that stuff. So these are things to be thinking about when we're assessing a patient. Other things to consider are that I've had patients who really never come fully back to their original baseline after having a delirious episode. So this is something else to think about. So what are some risk factors? So we kind of went over it with prevalence, but thinking about, if they're older, so reasons why it could be like the impaired acetylcholine neurotransmission, which is in the theory of delirium, they think is related to the cause of delirium. Vascular changes, pharmacokinetic changes that happen in the elderly population. And then major neurocognitive disorders represents one of the greatest risks for delirium. Polypharmacy, burns, low serum albumin is also commonly said as a theory for why delirium happens, and then drug and alcohol abuse. So these are just some of the many risk factors that a patient could have for developing delirium. And so something that I wanted to mention is that delirium can be deadly, as we saw with that statistic. But here are some life-threatening causes of delirium. So they have an acronym called WIMPs. And so I'm not going to go through all of this, but these are many different causes that can lead to death. And so it's really important to be looking out for this or keeping delirium on the differential. So how does delirium present? So the course would be abrupt or acute onset, waxing and waning. This is commonly a term, like terms that are used in test questions. You'll see something like where it's worse at night, and they have some other cognitive impairments. So it could be like attentional deficit, memory impairment, disorientation, executive dysfunction. They're disorganized, their speech doesn't make sense. They could have auditory visual hallucinations, their sleep could be completely messed up, they could have delusions, they could be labile, and so many things could be happening. So I think it's important to think about this and what else would be on the differential. So I think this chart shows some common confusions. is delirium versus dementia versus depression. And so some things that I want to point out is dementia is more, it has a longer length of time. It's not something that's waxing and waning. And so those would probably be the biggest things. You can also see in like alertness, like people with dementia, it's usually normal. Same with attention, but you can see orientation is impaired in both. And then depression, you see that orientation is intact. So these are things to consider. And then in terms of assessment, so you want to make sure you're recognizing it. You want to make sure that you're taking a really great history. Onset of delirium is the best clue to the causality. Any recent changes, so one example could be any new medications, but any other changes in their life, you want to make sure you do a thorough physical and neurologic exam, that you're really thinking about their mental status, that you're doing cognitive tests, basic lab tests, additional tests. I'll say like one of my CL attendings, she really likes clock drawings and feels like it says a lot about the patient. So, you know, now whenever I'm going for a delirium consult, I'll always ask them to do a clock. And then there's so many lab tests. So I would say doing the basic lab tests and then additional tests. We don't have time today to go into like how this would lead you to that diagnosis of delirium, but there are specific findings like on an EEG, for example, that would make your suspicion of delirium much higher. And then treatment. So the treatment for delirium is really reversing the reason for the delirium. But what you can do in the meantime is managing the behaviors, reducing those psych or behavioral symptoms. So one aspect is having a sitter. So it could be a sitter to, you know, prevent harm to themselves or others, or it could be a sitter because of behavioral concerns. You know, I have had patients who they just scream out constantly. And so we place a sitter with them to always frequently reorient them, make sure that nobody else gets hurt. And then as Jaclyn had mentioned earlier about non-pharmacologic interventions, those are very, very important. And I always make sure I put those in my consult notes. And these are just some of the many non-pharmacologic interventions. And it can be really as easy as making sure they have their hearing aid, their glasses, making sure the light is on in their room during the day. I've had patients where I've written an order saying like, do not wake them up unless it's very urgent. So we want to make sure that they're getting a good sleep. And then pharmacologic intervention. So we use like antipsychotics, cholinesterase inhibitors, benzos, and maybe in another talk we can go into depth about that. So really the take-home points would be delirium is an acute alteration in cognitive functioning with fluctuations in attention span and other symptoms. Delirium is serious, but very under-recognized, and frailty increases the risk of delirium. Management involves maximization of medical conditions with minimization of polypharmacy, and it's all about prevention, detection, and education. So I'm going to stop sharing. Thank you so much. I'll put my information in the chat. And I really appreciate your time and hope that this was helpful. And I really do appreciate feedback too. So please let me know if there's any questions. I'm always happy to answer them, or any like feedback or any comments.
Thank you to our speakers. Yeah, feel free to ask any questions in the chat if you have them. And then also, if you could fill out this feedback form, you can scan the QR code or the URL is on the screen, just so we can yeah, get some feedback on what we can do better and what we're doing well. And anyone who completes the feedback form will get sent a copy of these slides.